So welcome everybody to our Healthy Weight and Treating Obesity Community of Practice. I'm losing track of what number session we're on now. I think we're on our fourth one now. Just a very quick recap from our last session. So Will, as always, gave us an update on the Healthy Weight and Treating Obesity system work streams, and he'll be doing the same for us again today. We were joined by Benjamin Richardson last time, who was clinical lead dietitian at South Tees Hospital, and he spoke about whether the standard dietary advice that many have been trained to give is actually effective for weight management. So we do have a recording of that session if you weren't able to attend or if you want to watch it back again. So I will pop a link to that in the chat box in a moment for you all. Today, as I said, we're going to have another update from Will, and then we are joined by Dr Susanna Mills, who's consultant at public health at CNTW Trust, and she's also a research fellow at Newcastle University. Sadly, Dr Angela Rodrigues is unwell, so Susanna is kindly going to cover Angela's slides for us as well, but they're going to be presenting evidence-based recommendations for weight management supporting healthy weight in people living with severe mental illness. So without further ado, I will hand over to Will for the update.
No problem. Thank you very much.
Thanks, Will.
Right, I've got a slide deck to go through that just gives you a bit of an update on all the work. So I will just share my screen and I'll probably lose everyone. So if okay, just hold fire and we'll do questions at the end if that's okay with everyone. Just start the slideshow. So hopefully everyone can see that. So just brief introduction. I know a few people on the call, but my name's Will Smith. I'm the Healthy Weight and Treating Obesity Strategic Manager for the North East North Cumbria ICB, and I have a clinical lead who works alongside me, who's Arachelvan Vijayaramam. He's a diabetologist and endocrinologist, and he runs a Tier 3 service out of South Tees Trust and been doing that for the last 15 years. So blessed to have him on board supporting the work stream. So just a little bit of background. I've previously kind of gone through this before, but it's just to reiterate it. The work that we've been doing started back in 2021, and one of the things that we were tasked with doing was bringing it all into a...
They never look this way, are they? It's difficult.
Oh, sorry, just put participant on mute. We were started back in 2021, so we were tasked with bringing all the work that we'd done together into a strategic oversight. We did a lot of engagement work with the system and held a huge event. And what naturally kind of teased out of it was 4 strategic themes that we're now working towards. So we're looking at a whole system approach, which our public health colleagues in local authority will be very, very familiar with. We're looking at advocacy around the food environment, so in terms of the advertising, understanding of high fat and sugar and salt foods, service provision in terms of what's actually available out there, and then workforce in terms of our current and future workforce. And it's all underpinned by 2 key things: comms and engagement and data and intelligence. And I'm obsessed with data and intelligence, and we've got lots of information that we use to make these decisions. So just a little bit of update in terms of the whole system approach. One of the things that we're looking to do is develop an ICB-wide healthy weight declaration. And that's in terms of working with organisations, looking at mechanisms and how we can increase physical activity, reduce stigma, look at opportunities in terms of the food choices and what's available, and how we can focus our environmental side of things to make it in terms of more informed choices and supporting our patients and our workforce around the healthy weight agenda or healthier weight agenda. We're working with Food Active, who've done that. We've held a number of events across the whole of the ICB patch, and what we're looking to do is develop a report from these events, and it will help us with the logic model, and we're looking to commission them to help us to implement the healthy weight declaration over the next couple of years to get it out there and work with organisations to support this ICB-wide piece of work. Advocacy in the food environment links very, very closely with theme one anyway, because what we wanted to do is that we previously had a commercial determinants of health conference, and it kind of raised significant awareness about the kind of the food tactics, the tactics of the food industry and what they do with the buy one get one freeze and all that kind of side of things. So we're looking at commissioning an organisation to help us do the insight with the public around, is that something they're interested in? Is that something we need to kind of look into and develop and think of it from a people perspective, not rather than expert perspective, because we have our points of view and our thoughts on it, but we need to be aware of kind of what people think and how we can look at changing the messages and our approaches as well. That's if people want to. So moving swiftly on, theme 3 in terms of service provision, it's been plastered all over the news for about the last 6 to 12 months. So in 23rd of December 2025, sorry, they released the interim commissioning guidance for the tirzepatide, and that there was an expectancy that it would be available in tier 3 and primary care. So just from the northeast and North Cumbria's point of view, what we did was we worked and we developed a locally enhanced service specification for it to be delivered via primary care with support from the National Wraparound Care Programme. So we had the Expressions of Interest portal open throughout the summer, and we extended it right through to the 12th of September for GP practices to opt in to either deliver it as an individual practice, as a cohort, or the opportunity to deliver additional patients. And what the process is that they would be looking to see patients, assess them, check that they met the criteria that's within the interim commissioning guidance as well, which is very strict in terms of BMI of over 40 with 4 out of 5 prescribed comorbidities, that being cohort 1, and then the cohort and changes over years 2 and 3. This has all been determined by NICE and NHS England. It was not determined by the ICB. We do get a lot of queries around that, but what we've done is look to work to get that out to our system, utilising the kind of the constraints and the criteria that was set out by NICE and NHS England as well. So that's out there. So just a little update, this is probably out of date already. It kind of changes every day. I kind of speak about it. So to date, we've had 317 responses with 306 out of about 350 or so practices across the northeast and North Cumbria said yes, they would deliver it. And 11 saying no, they wouldn't deliver it. What we're hoping to do is we'll get another update to see if we've increased that number to make sure we've got a good spread across the northeast and North Cumbria to kind of reduce health inequalities. The system runs on what we call a prior approval ticket. So when the GP gets a patient and assesses them that they meet the criteria, they do a prior approval ticket. That's just to help monitor with numbers and facts and data collection as well, because there's a national cap on it. But what we're looking to do is just operate and see where we go with it, because we kind of, 3 or 4 months in and it's at a steady pace already. So we think we're doing okay. So 299 of them are being processed. To do it, they have to be, to get access to drugs, they also have to be referred to what we call the Behavioural Support Obesity Programme, and that's the wraparound care, and that's to meet the commissioning guidance and the NICE guidance as well, that to be prescribed the drugs, you've got to go on a wraparound care programme as well. At the moment, there's a slight lag in uptake in between the number of PATs processed and the BSOPs. So once I've got an update on that, I'll do that. As I mentioned, the portal for sign up to Les closed on the 12th of September. So we'll update those and hopefully we've got a better spread. For areas that don't have a practice that's signed up to Les, what we're looking at doing is using the right to choose pathway to fill that gap, whilst we look at the kind of the next steps for cohort 2 and what the other options are going forwards. And there's just a little bit in terms of the overview of the BSOP. Key things to look at is that they are looking at the options of face-to-face, but that is based on the numbers available. And I know over in kind of the Cumbria neck of the woods, this has been a little bit difficult, and we're looking at what the options are around that as well. The majority of the programmes covered via a tailored remote. So what they've done is specifically written a programme around people getting prescribed tirzepatide and the physical activity guidance and the nutritional guidance go alongside that. There is a digital service that's delivered by Second Nature, and it's an app with interaction with lots of kind of online one-to-one support, group messages and online communities as well. And it's a key part of it. They've got to be engaged with it, and as part of the process that they have to have ongoing engagement with the programme. There is a little bit of leeway, but we have to make sure that patients appreciate that to do the drugs, you've got to have the wraparound support to support with those long-term lifestyle changes as well. The other element of it as well, within the funding variation and the nice TA saying that it had to be made available from tier 3 weight management as well, there was a little line in there that allowed you to look at aligning your cohorting for tier 3 with primary care. So what we've done across the North East and North Cumbria, we developed a healthy weight treating obesity patient prioritisation guideline that aligns the tier 3 prescribing criteria with the primary care prescribing criteria. The reason being with that, what we didn't want to do is create a kind of a glut of referrals to tier 3 that already has a significant number of referrals as well. So what we're looking to do is make sure it's aligned and it makes it fair for all patients as well and provides support and guidance. For tier 3 as well, we've got additional kind of criteria in there that's linked to if they've got a time-sensitive intervention such as IVF or a kind of a transplant, means things of that you could go out with the main criteria as well. We've got 4 services that they've got access to the drugs, and that's building up slowly but surely. But the key thing that is kind of slowing that down is the opportunity of how you can do the prescribing in secondary care, because it's not straightforward within primary care. Just a little bit, we constantly use the digital weight management, which is a national programme, and we've done lots of work around that. I'll share my slides, but essentially we do really well with that. We typically get about 80% of the aligned numbers to us taking up the option. To date, we've got about 2,500 eligible referrals who've opted in the programme. We predominantly get the majority from IMD 1 and 2, which is good. Good split between male and females, and we're doing okay in terms of our national targets, and that we're typically sending the most eligible patients to the programme, which is credit to the referring professionals and the work that we've done to raise awareness about the programme. Workforce, we have via Boost, we have the online School of Healthy Weight and Treating Obesity Studies. We started back in November 2024. To date, we've got 429 people registered. Over 988 modules are being completed. We've got 24 live modules, and we're doing lots of work on developing local content in terms of stuff about bariatric surgery, about the drugs, about disordered eating, specialist diets. So we're doing lots of work, and the key bit around it was to support the current workforce, but also look at the future workforce who might be interested in work in this kind of area, and give them most up-to-date information as well. Ben Richardson has done a module for us as well. We've done psychological factors in weight management. We've got upcoming modules around emotional and disordered eating and obesity in primary care developed by a local GP as well. So that's coming. And then just make you aware, some of the work that we're doing is, you might have seen it, there's a national programme, Obesity Prevention Innovation Programme, where there's £85 million available. It's in 3 strands, and you probably can't see it, but essentially it's access and management services, care pathway services, and a combination of the 2. It's 3 strands. You can bid for 1 or all 3 strands. North East North Cumbria ICB are going to put a bid in, and we're utilising Health Innovation North East North Cumbria to support writing that bid. The key elements about that is they're looking at very keen on community pharmacy models, digital models, and how we can look at getting more access out to the community and see bigger numbers as well. So that's going to be a big focus of that bid as well. The funding doesn't include the cost of the drugs as well. It's all about kind of access to get people into services and support with services. So that whole kind of wraparound programme. And yeah, my slide didn't quite work as well as I wanted to. It was supposed to do it the other way around, but essentially that's what it is. If anyone wants more additional information, by all means contact me. I'll put my email address in the chat, and that's my presentation, and happy to take any questions.
Brilliant, thanks, Will. Please feel free to come off mute or pop any questions in the chat, and we can field them. I know there's been a comment from Helen, Will, just to let you know. She was wondering whether a Healthy Lives banner can be used instead of Healthy Weight. So she has popped Nutriri's kind of evidence around that as well in the chat for you.
Yeah, thank you very much, Heather. Helen, sorry. Was Helen or Heather used today? Sorry.
Helen.
Helen.
Any questions for Will? No? That's
Hi,
unusual. Oh, here we go.
sorry.
Lovely. Go on, Alex.
Hi,
Thank you.
So just hello everyone. I'm one of the new ST1s in the public health training program. So I'm quite new to this, so maybe a silly question, but I just want to ask about in your slide about patients who were prescribed the GLP-1 agonist drugs, they had to be referred to the BSOP program. You said about 209 referrals being made. I'm assuming that there'll be kind of follow-up monitoring people's engagement into that program. I was just wondering what the statistics are around that, just because I only saw on the slides about the referrals being made to that program. So yeah, just a question about follow-up on patients engaging with the program. Thank you.
Only just started, so we only just started the program in kind of about July onwards. So that's when we'd finished doing the expression of interest and that GP practices referring into it. So of that number, we don't have any details in terms of engagement as yet, waiting an updated report. But the key things is it's a national contract, it's via NHSE, so they have to do ongoing checks in terms of with the patient, weighing in any kind of additional information they want to share, doing physical activity and engagement with the programme. And there's lots of kind of criteria about regular attendance, engagement, and if they fail to attend and engage with that programme, then they risk the possibility of being removed from that programme, which would then remove them from the prescribing of the medication. It's a difficult one because everyone wants the medication, they want to be engaged with it, but it's got very, very strict criteria that was aligned via NICE and NHS England in terms of a whole group of experts around the best populations and the clinical populations to start with. Because if we'd have just done it by the initial NICE TA that suggested the BMI of over 35 and one comorbidity, 3.4 million people would have been eligible across the whole of the UK. And if you work it out between £1,500 to £2,000 per patient, if you do the maths on that, it doesn't quite work out. So it all was kind of looked at clinical populations, and they decided the BMI 40 plus the 4 out of the 5 prescribed comorbidities came up with a rough population, about 220,000, that they wanted to trial access over the first 3 years, and that the funding variation linked to that would allow access to the drugs to everyone over a 12-year period. But there's an initial 3-year evaluation to see that we've got it out to those patients who needed it most whilst we look at opening up access. But as you can imagine, in that time, probably about another 1, possibly 2 drugs will be available, and that will change the landscape again.
Well, thank you very much. That was a really interesting talk, and thank you for answering my question.
Not a problem.
And I got a question from Paul.
Well, yeah, it's just a quick one. Out of the 11 who said no, do we know if any of them were in North Cumbria area? Is it split down that way, or?
We've literally just got the spreadsheet finishing off this week to terms where our gaps are and what we need to do in terms of areas with gaps. So make sure that they know that they can utilise the right to choose pathway while we work on what the options are for next steps. So as I quickly kind of outlined, there's 3. We're doing a 3-year implementation. So cohort 1, BMI 40, with the 4 out of the 5 prescribed comorbidities. Cohort 2 reduces the BMI between 35 and 39.9, but with 4 of the comorbidities. And then year 3, it goes back up to BMI of over 40, but 3 out of the 5 prescribed comorbidities. So what we're hoping to do is we're looking at rejigging, doing the LES for the next steps, and that we're hoping as time goes by, practices will talk to each other, how easy it was, what worked, what didn't work, and hopefully we can get full coverage across the whole of North East North Cumbria if possible, but I don't think it'll ever be 100% possible.
Yeah, no, that's cool. Thanks.
No problem.
And if we just take one last question, because I'm conscious of time, Helen.
Sorry, has it unmuted? I just realised
Yep.
I got it set up properly.
We've got you. We've got you.
There you go. Morning, Will.
Morning.
I've popped it into the chat as well, because often I'm not so clear spoken as I am typed, which is amazing being dyslexic, but there you go. Yeah, I wonder what your thoughts are around how much sort of like current work is creating space, not just to work weight inclusively, weight neutrally, but also for people that are contraindicated for medications, for example. So it seems to be, you know, you either need to be changing weight for health, or you need to be pursuing medication if you're in that BMI bracket. You know, how much focus is being brought to working without surveilling weight as an alternative method to raise engagement?
In terms of the work that we're trying to do is that we're doing a lot around the weight stigma and conversations, and we're trying to get more and more modules up about that. I suppose the difficulty is that it's a whole scale movement to do that. So we need to do more alongside that and bring that on board. And I suppose it's stuff that we need to add to the work that we're doing in terms of the whole system approach, and work with that and look at how that could be brought into it. But one of the key things is that we said with our strategic approach, it's meant to be weight centric, not weight centric, patient centric, in terms of what the needs are of the patient, and trying to look at it as a whole rather than we solely focusing on weight. And some of the key things is that when we look at our criteria, especially within the patient prioritization, is that we look at, as in, is there a time sensitive intervention? Is there like things that supersede the overarching criteria? And one of the things as well, we're trying to focus on the health inequalities of it, because what we found, particularly with the medications as well, it's often those who shout loud enough are the ones seem to be kind of pushing their way to the front of the queue. And what we're trying to do is skew it the other ways in terms of those who need it most get the medication as well. So from a clinical point of view, particularly with tier 3 as well, because that's a sensitive area as well, is that people within that service were shouting and saying, well, I need it, and demanding it. And what we've given them is guidance for the clinicians to make a clinical decision and guidance on that.
Yeah, I think if we're not focusing on the people that aren't shouting, I'm not just talking about that we should be prioritising them for medication. I'm saying we should be prioritising them for their health needs, which is often, if they've got a history of disordered eating or eating disorders as well, not saying that they all do, but there's definitely people in that cohort that need to have a non-weight surveilling provision, whether that's behaviour support, whether that's just engagement around their long-term health conditions, and not forced engagement around their weight. So yeah, I popped in the chat a bit more detail, because it'd be really good to be linked in as an organisation to any teams on OPIP, also putting their bids together for OPIP, but also any local teams that are working on the National Neighbourhood Health Implementation Plan, because Newtrury, over 10 years, we've developed, you know, this community training that's built by the community, whether that's workforce or citizens, you know, to explore the data and the evidence, the really robust evidence around not surveilling weight. You know, but what we need help with is how that sits side by side a weight management provision, because I think it's misunderstood that when we're talking about, oh, we need weight neutral, that we're opposed weight management. Absolutely not. What we need is weight inclusive triage. So that first step.
There's a lot of work that we're doing around with the specialist weight management services about that, what you just mentioned about disordered eating and eating disorders, and that they are a core that we have to be very sensitive with, and their pathway is completely different. So it's in terms of understanding what's going on with them, and then it doesn't become, like you said, about weight, it becomes about the changes and the support that they need as well.
Yeah, but having a more balanced view of health management, it will reduce the demand of these squeaky wheels that are shouting for the medications, and that will give us time to actually realise what the real impact of mass prescribing is going to bring. You know, we need to sort of like be a bit more balanced in our approach. So yeah, I'd love to speak more about that with you at some point.
Yeah, no problem.
Brill. Thank you ever so much, Will, for coming along and sharing that update with us. That's great. I'll now hand over to Susanna.
Great, thanks very much, Ashley, and thanks for an interesting discussion already this morning. So, as Ashley alluded, you've got a double whammy of me rather than complemented by Angela, so apologies for that. We're going to sort of break the morning down into two short presentations with time for discussion afterwards. So happy for you to eject if you do have questions for clarity, but otherwise perhaps we'll just rattle through the first presentation and then have a group chat about that subsequently. But overall, our focus, I guess, comes back to some of the discussions we've already had this morning about being inclusive, hearing those voices that are often seldom heard, and making sure that we do that in the most effective and productive way possible. So with that, I shall share my slides. And perhaps could you give me a verbal, Ashley, that's okay, just because I can't see everyone.
Yeah, we've got it. Thanks, Susanna.
Brilliant. Okay, thank you very much. Okie dokie. So, as Ashley said, my name's Susanna. I work across Cumbria, Northumberland, Tyne Wear NHS Trust, and also at Newcastle University. Got long-standing interest around diet, nutrition and obesity, but particularly the intersection with more vulnerable groups, of whom people experiencing mental illness would definitely constitute one, and that's some of our focus for this morning. So, there we go. So, I appreciate we've got a varied audience. Some of you will be more familiar with some areas of this talk than others. So just for clarity, we'll cover some of the terms as we go through. So severe mental illness, or SMI, usually includes people living with schizophrenia, bipolar, related psychotic disorders. And sadly, they experience both an unfair and avoidable mortality gap. So people tend to die 15 to 20 years earlier than the wider population. And actually, generally, this is due to their physical health conditions, which in turn are underpinned by a range of public health risk factors, in particularly development of overweight and obesity. So we know whatever someone's nuanced experience of that is, that support for obesity and indeed their wider holistic health is definitely needed. So overweight and obesity are a particular challenge for service users living with severe mental illness, but also particularly in secure mental health settings. So those are effectively locked wards where people are held because they pose a threat to themselves or to other people. And people tend to stay here for months, if not years, rather than days or weeks. So a setting in which we have quite a static population, but lots of the circumstances mean that it is much more conducive to people developing overweight and obesity. I think it's also worth flagging, as we've already touched on this morning, that there's a bidirectional, if not far more complex relationship between mental health problems and excess weight. So really, I don't think we should be trying to address these issues separately, but in a much more holistic manner that considers both ends of the spectrum. Furthermore, as we've already touched on a little bit, unfortunately, people living with severe mental illness are often systematically excluded from both more advanced obesity treatments, so things like Tier 3 and Tier 4 weight management services and some of the weight loss drugs, but also some of the research trials that support that evidence-based. And really, that's quite unfair when you look at that from a health equity perspective. So I could have shown you lots of data to illustrate the point here, but just on the left here, you can see the prevalence of different physical health conditions for people living with severe mental illness. On the far left, you can see that people are almost twice as likely to be living with obesity, if not higher, really. And then on the right here, we've got a forest plot, which essentially draws together the evidence from lots of different published research studies. And again, you can see that the odds of developing overweight and obesity is much higher for people with severe mental illness, here in the region of 3 times as high. To a certain extent, this has trickled down into the UK policy context. We've had lots of policy changes recently with the new Labour government and some of their plans for the future. But I think arguably this hasn't necessarily always changed into tangible changes in practice in terms of integrating physical and mental health care. So I've mentioned briefly about the secure care setting or forensic mental health hospitals, and these are a particular focus of the research I'm going to present today, because ultimately they do tend to present off the most extreme end of weight management issues in the severe mental illness population. What used to be Public Health England is now the UK Health Security Agency, published a systematic review back in 2017, so quite some time ago now, but it's still our most recent evidence base. And here the main point that they highlight is that we really need more evidence for supporting obesity management in secure settings. And this small infographic here shows you some of the interlinked features and factors which underpin some of the complexity of this environment. I also wanted to bring this back to the individual service user perspective, because from a population point of view, we talk a lot about groups of people on a population level, but ultimately talking about individuals with really quite nuanced experiences. So as an anonymised example, I wanted to introduce you to Jack. So in his late 20s, Jack started to hear voices, and unfortunately this led to him to attack his brother with a knife. Jack was subsequently diagnosed with schizophrenia, taken into a mental health hospital in a secure setting under the Mental Health Act. He's been managed extremely well with antipsychotic medication, and his psychotic symptoms have subsequently improved dramatically. However, his physical health has really deteriorated. He's put on over 4 stone in weight. This has tipped him into developing type 2 diabetes and some related physical health comorbidities. And sadly, far from being an anomaly in this context, Jack's experience can often be the norm in secure mental health settings. So this was really a key driver for underpinning a programme of work which was funded by the Academy of Medical Sciences, which used mixed methods and a key approach for stakeholder engagement. So we were really getting that lived experience voice to try to understand the complexity of this picture more. So just in brief, we undertook an anonymised staff survey of all staff working in secure mental health services at Cumbria, Northumberland, Tyne Wear Mental Health Trust. And then the findings from this survey went on to inform an ethnographic approach, which essentially means that I spent time on a low male mental health secure ward to really see what does and doesn't happen in relation to weight management practices around food and physical activity in this environment. Because with the best will in the world, we can have policy, but this isn't necessarily implemented in practice quite as we would intend. And again, the findings from these 2 streams of work went on to inform a set of focus groups and interviews. The focus groups were undertaken separately with current service users, former service users, multidisciplinary staff and carers to really get a feel for people's views and experiences around weight management in this context. And this was complemented by a set of 11 semi-structured interviews that were undertaken with staff in secure services working at Tees, Esconway Valleys Trust to really see what was the same and what was different across trusts in the North East and North Cumbria. And then obviously we brought the data together to a triangulation approach. And again, we work with a multidisciplinary and lived experience team to try to make sense of that data as a whole in terms of our key messages and findings. So overall, I think just to re-emphasize the point that perhaps we should be doing things differently in future, when we ask the question, is weight management well addressed in secure services, only 23%, so less than a quarter of respondents agreed or strongly agreed with this point. And when we looked at the key salient factors that underpinned this, we can see on the right here, overall service users are living in what we term an obesogenic environment, which can be perceived as a pejorative term, but basically is a catch-all phrase that helps us to understand that it's much more conducive to people living with an unhealthy weight rather than one that is healthy. And it helps to shift that burden of perhaps perception of guilt in terms of why people might be experiencing that. And just briefly, people's journey of weight gain was often precipitated by starting using antipsychotic medication. And although we know that this is a recognised side effect, often a timely conversation wasn't being had in terms of that steps to address or mitigate that. And we're going to talk a lot more about that in Angela's talk that comes up in the second part of the presentations. Often people have quite sedentary behaviour. They're not able to participate in physical activity and exercise, and often have quite low motivation to do so, and also to eat well. Often this is underpinned by their experience of severe mental illness, and often the medication also that they're receiving. It may not surprise you to hear that there was more or less universal dislike for the hospital-catered food provision, and so people would seek out alternatives, but often those that were the foods that were high fat and salt and sugar, that were brought in by family and friends, or perhaps available from the hospital shop, or if they did have leave trips off the ward, if they went out and about, perhaps for a walk to the seaside, for example, that was often accompanied by fish and chips and ice cream. So not perhaps making that balanced, holistic approach to health that we might desire. Role of staffing is obviously hugely important, both in terms of role modelling, but often the fact that often understaffing levels meant there wasn't really the capacity or time to be having more health promoting conversations with service users. And often staff described being quite frustrated because they felt that they were faced with a dichotomy or a tension between optimising patient choice, when lots of their choices had otherwise been taken away, and optimising patient health. So again, that more holistic model was more difficult to implement. I won't go through all these at length because I think we'll have plenty of time for discussion afterwards, but basically to show that we did have some potentially conflicting views between our respondents, which I think helps to highlight that the nuanced experience that people have within their experiences of weight management in the setting. They had different voices coming through in terms of service users, carers and staff. Service users, not surprisingly, often focused on their experiences of choice and rights, and as I mentioned, really quite dissatisfied with the hospital food provision that they received. I think former service users and carers were often able to adopt a bit more longer term perspective in terms of behaviour patterns and their concerns about potential implications for health. And as I've mentioned, staff often really felt quite frustrated about the challenges they experienced and how the environment and individual experience were not holistic of that overall health picture. So we developed a set of 8 recommendations, which you can see here, and we'll talk through when we come to our discussion groups, but also to highlight particularly at the end, recommendations 7 and 8, I think talk to perhaps more beyond the weight management setting and indeed secure care. We probably should be adopting a much more health-focused culture that is much more person-centred rather than service-centred. And obviously going forward as our population ages, we need to be better about delivering a more integrated approach to multimorbidity rather than one that is segregated into different services. If you'd like to see more, we've published this research in the public domain, so you can access these papers freely. Again, we could talk for a long time about the GLP-1 injectable weight loss drugs. I just wanted to highlight a couple of points, really. I think these are an opportunity for making great strides in terms of supporting people who are experiencing really significant burden of weight alongside comorbidities, but we really need to have inequalities at the centre of that. We talked already about how some of the discrepancies can develop when people are more perhaps able to speak loudly in terms of their need and those who we don't hear so well. Potentially, we're also medicalising what is essentially a public health issue, and we can't treat a way out of this problem. And also, we need to be mindful of the potential longer-term effects of medications, and really that isn't borne out yet in practice because we haven't been administering weight loss drugs on a wide scale for long enough to really know what those implications might be. I'd like to acknowledge the support and funding for this research, and we'll break into our discussion groups as well to have a longer chat. Thanks very much.
Brilliant. Thanks, Susanna. Before we go into breakout rooms, has anybody got any questions on what Susanna has presented so far? All good? Okay, just bear with me one second. I'm just going to pull up the slide with a couple of questions on it that we would like you to discuss in the breakout rooms. Just bear with me one second as it reloads back up.
Ashley, is it possible that you could...
I've sorted it, Heather. Yeah. All good. I spotted it. I sorted it. That's all right. No problem. So what we would like you to discuss in your breakout rooms is what does the evidence suggest about what works and what doesn't, supporting healthy weight in people with severe mental illness. And then the second one, how can we amplify the voices of lived experience throughout this work? If in your groups, it would be much appreciated if you could agree to just have one scribe, because it would be great just to capture some of the things that you discussed. So I've set up a Google slide there. So if it only needs kind of one of you in each group to be able to access this, I'm literally just going to pop a link to it in the chat as well. But yeah, if you could agree a scribe between you just to jot down some notes of your discussions, that would be much appreciated. Just make sure that you're on the right slide because you'll see all of the different rooms on the left-hand side. So just check what room you're in. It should tell you on the top of the bar when you go into the breakout room what number you're in. So just make sure you're updating the right one. Okay, any questions? I'll probably aim to give you guys about 15 minutes just so you can quickly introduce yourselves as well. Okay with everyone? Brilliant. Okay, thank you ever so much, everybody. I will now hand back over to Susanna for the second half of the presentation.
Brilliant. Thanks, Ashley, and thanks for such a thought-provoking, engaged conversation that certainly we're having in our room. So again, apologies. We originally had intended to have Angela deliver this next presentation, so it's going to be more halting than I would have liked. Also like to acknowledge that we've got Sally and Craig in the audience who are probably better versed in this research than I have been in terms of the implementation delivery. So if anyone would like to chip in at any point, then more than happy for you to do so. But with that in mind, Angela's developed some excellent slides. We'll go from those in terms of her content. So we'll bring this up now. Okay, and again, I'll just wait for a quick verbal, Ashley, that you can see that okay.
Yeah,
Lovely.
we've got it.
Super, thank you very much. So this is going to pick up from where we left off before in terms of people's experience of both severe mental illness and overweight and obesity, but we're going to pivot a little bit more now to think about the particular experiences about people's conversations that they're having around obesity. And I think this really speaks to some of the discussions that we were having about how we frame some of these health issues, how they're addressed, and the importance of, for example, avoiding stigma and make sure that we're taking a holistic approach. So we're going to briefly go through the methods, some of the key themes from the interviews, and then some of the implications for practice. Firstly, MEC, making every contact count. Just to recap that MEC's, it's a long-term strategy. It's been adopted by trust and local authorities for nearly 15 years now. It's defined, certainly by some groups, as a person-centred, opportunistic health behaviour change approach using theory-informed techniques. So it's really got that kind of rigorous underpinning, which means that when people are having health-promoting conversations, they're doing that in a much more directional, strategic manner that aims to improve health. And MEC specifically provides training materials to support more public-facing workers, so people who are engaging with service users and patients. Oh, let's flick back. During the routine contexts that people might have. 5 core elements of MEC, including smoking, healthy eating, physical activity, alcohol, and mental health, which arguably are all very much interlinked and related to each other and be difficult to address those in isolation. Broader definition in terms of MEC Plus also considers those wide determinants of health and well-being, which I think are really fundamental to all the considerations in terms of what activities people undertake or don't in terms of their health. I think these must be automatic slides, so I might have to flick back and forth. But these are some of the perhaps social and health inequalities that people might experience, like debt management, housing and welfare. And we know that they're really salient to people who are living with severe mental illness, who often have this cards very much stacked against them in terms of their wider determinants experiences. So in terms of the MEC training package at CNTW, the objective here overall is to improve self-confidence and people's perceived skills in terms of delivering MEC. And there's sort of a multi-pronged training model, which uses a train-the-trainer approach, which essentially helps to upskill people and they then disseminate that learning to others in terms of the staff and contacts that they have. So people are cascading their training onto peers, which is a really effective way of that kind of domino effect of integrating learning. There's bespoke training, which includes the core MEC training, but also additionally a Weight Off Your Mind programme. So just to recap, a Weight Off Your Mind is a regional management initiative or plan which covers North East and North Cumbria, which ultimately supports individuals living with severe mental illness and or learning disabilities to support them in a healthy weight. And it focuses really on the lived experience of this, but in particular activities around exercise, physical activity, healthy diet, and the other kind of wider underpinning factors. So the specific research aim was to explore service users' perspectives on weight management conversations, focusing particularly on people who are living with severe mental illness, who are both inpatient and community-based. We really want to understand more about how service users understand what MEC conversations are and whether that matches what health professionals perceive and what they intended. So we might term that in terms of fidelity. How close is it to what we intend? So qualitative, semi-structured remote interviews, which included inpatients and community-based individuals with current or previous history of severe mental illness. We recruited using purposive sampling, which essentially means that we were able to take practical steps to tap into population groups who perhaps we weren't accessing. So for example, if we know we've got a preponderance of males, then to seek out females to make sure that we had a more comprehensive approach. Microsoft Teams was used. I believe that some of that was because of the still impact of COVID in terms of some of the constraints about in-person interactions. But the interviews were audio recorded and transcribed so that we could access the data afterwards. and data analysis undertaken using an approach called reflexive thematic analysis, which is essentially taking a comprehensive view of what people are sharing and pinning that onto a more theoretical approach with appropriate ethical input, as you would expect. So 13 service users were involved, 9 inpatients and 4 community service users. And the 4 emerging themes, which I'll talk about more here, are experiences of the weight management conversations, the development of therapeutic relationships, which has already cropped up in conversations this morning, clearly hugely important. The support that healthcare professionals received, and then a more, I guess, thick or descriptive element of the MET conversations that were undertaken. So firstly, the experience of weight management conversations. I think it's really important to recognise and so I guess kind of validating and it's exactly as you would assume that service users often felt embarrassed or judged using the weight management conversations, which could lead to reduced engagement. So I think that's really key for learning in terms of how to implement this more effectively in future, is reflecting on how people actually felt. You don't want to feel as if you're being judged. Obviously, there are situations where they have to be straight to the point and frank about it, but obviously some people were uncomfortable. So in terms of developing these more therapeutic or constructive relationships with the healthcare professionals, positive impact of building relationships was really key. So it was seen as beneficial for service users, helped them to gain advice and encouragement for healthy behaviours. So as this participant mentioned, they basically put things in perspective for us, allow us to see the bigger picture and understand where I'm at. I'm in hospital at the end of the day, you can't have access to all the food that you'd want. I think that we're reaffirming that positive mindset as well. So again, coming back to how important the mental health aspect of this physical health experiences might be too. So delivering the weight management conversations, people really wanted to have a sensitive approach to be undertaken when having these conversations that related to lifestyle factors, and key was to avoid triggering an adverse mental health outcome. We know that, as we've already touched on, the stigma and triggering aspects of addressing some of these really sensitive issues is really important. As we might expect, having a friendly approach really helps service users to feel at ease and much more willing to engage with healthy lifestyle conversations. So I feel it has to be an error tact about it. How to approach it, how to deal with it, obviously varies from person to person. It needs to be a tailored support. So how service users describe or recall their MET conversations. I think it was interesting in terms of to what extent people were able to recall the exact step-by-step conversations or how they kind of perceived it as a whole. And I think that's probably true of all our recall experiences, really. So some remembered MET conversations about weight management, diet or lifestyle behaviours. And some of these interactions included brief advice or brief interventions, so some verbal guidance on topics, which might encompass things like sugar reduction, healthy eating, steps to being active in your day. As one reflects, with one lesson talked about, well, wait with her. I've done all them chats, they're on the page now as well. So talking through some of the different salient points for them and their learning. So key conclusions here. People had mixed experiences of weight management conversations, some experiences around fear of judgment, loss of control, around the medication related weight gain, some of that perhaps stigmatizing language or people feeling judged. They really did, however, value some of those referrals to dietitians or the more constructive support for physical activity. Therapeutic relationships, as you can imagine, hugely important, and that trust, sensitivity, avoidance of stigma was critical for engagement. Friendly but yet direct approaches that did get to the nub of the problem and didn't kind of dance around about it, but also were supportive and tailored where people's individual experiences were considered. And in terms of barriers and gaps and potential areas for development, there were sometimes some limited proactive discussions around medication side effects and an inconsistent engagement with MET conversations, which I think comes back to maybe the first presentation around perhaps some of those limitations on time and the more health promotion side of things that some more support would be helpful with. And stigma, as we've mentioned, was salient to all of those. So in terms of recommendations, now we're going to talk a bit more about these in the breakout group, so I won't elaborate too much on these, but essentially communication approaches hugely important. The strengthening of therapeutic and tailored conversations and relationships, also the trust aspect is clearly really underpins all of this. And then training and practical support. There we're thinking more about what we might do differently in future in terms of how we might support both healthcare professionals and other people who are supporting service users, how we might do that in terms of tools, resources and relationships going forward. And I think this is up to our last slide. Yep, thanks very much for listening. And I'll come back into the main forum now. Thank you.
Brilliant. Thanks, Susanna. I'm conscious of time and also the numbers that we currently are. So I'm wondering whether we just do this bit as a larger kind of group discussion might work better, I think. So just bear with me again a moment. I'm just going to share the slides with a couple of questions to kind of get your thoughts. But if anybody wants to share any reflections in the meantime, please feel free. Oh, I'm having great tech fun today. Bear with me. Because I'm on one screen as well, which I don't think helps.
Well, thanks, Ashley. I think in the meantime, Helen shared some useful resources. Do we save the chat from these discussions, Ashley, or are you able to kind of share that afterwards? I'm just thinking about referring to some of the notes for people.
Yeah, we might need to just copy and paste. I know I can get back into
we could
it
do that
afterwards.
Yeah,
so
okay.
So yeah, we can
I
share
pasted it into group 4 on the Google Doc as well, because I didn't know which group
Fabulous.
I was in, so I just stuck it in there.
Brilliant. Yeah, because I'll download those and share them out afterwards as well, all of the notes from the discussion group, so people can also have a little nosy at what was sort of discussed in the other ones as well. So yeah, fab.
Just to add in that excerpt, can't say that word, that I have included there. I don't think that is published yet, but it will be. It's been submitted as written evidence for the current inquiry into food and weight management. So it's sort of like shared in confidence for now.
Brilliant. Okay, thanks, Helen.
And it's not my work, so
okay.
Yeah.
No worries. Brilliant. So these were the couple of questions for you all. So what do you feel are the barriers to implementation in real world settings, and how might we overcome them? Any thoughts on that one? Oh.
I'll just give my usual rant about how noisy it is kind of online with social media and everything at the moment. Try to get any messages out that people aren't already tuned into in their algorithms is really, really tricky, especially health messages. So obviously this is more about implementation, but sometimes before implementation, it's getting people to the service or whatever, isn't it? So maybe a lot of it is going to be done more in person, because I think the virtual things are that, what's the word? Just
kind of gets
overrun.
Diluted, kind of. Yeah. It gets lost in it.
It gets lost, and it's hard to get, especially health messages, because you know, there's probably cats and dogs doing incredible things that people would rather see in their feeds, or whoever. I was going to use Taylor Swift as an example because it's me, but you know, whatever you're into tends to fill up your feeds, doesn't it? So if you're not into healthy things, it's very hard to get through that algorithm to people who haven't got that in the feeds. So I suppose that's before the implementation, but it's probably still something to think. How do we get to the groups, and is it more of an in-person thing now? Yeah.
Brilliant. Thanks, Paul. Then got Louise.
I think we live in quite a crazy and diverse world. 2025 is quite something. I think there's people with opinions on lots of things. For me, I think it's about getting it right. It's the right people going about it in the right way. And I think the making every contact count is brilliant, and people cascading that down to team members. But again, those team members have to have the confidence and competence to then go about it with their own, people that they're working with. It's not a one size fits all. So, just having had the training doesn't necessarily mean that person is then confident to deliver that training in the way that somebody else can. So I think, if we're identifying, if we're aware of that, then I think we're partway there. I think as well, something to consider is that, especially with people with mental health diagnosis, some people will struggle to have a lot of conversations, not just around weight, but anything that might evoke that, that they may be scared that that's going to evoke a reaction, a response that makes that person more unwell, or makes them, hit out, or a number of things. So it's not just this topic specific. It's, you know, it's about anything, isn't it? Giving up smoking, it's about making better choices, it's about how they spend their free time. It's any of those conversations that people find difficult. So again, working holistically in terms of in that context, not just looking at this topic in isolation, but doing the broader, you know, how do we approach a difficult subject with some people, you know, and working with what's out there already, you know, is that information already out there and better known, and working more holistically with others. But that's my ramblings for this morning.
No, brilliant points in there, Louise. Thank you. Helen.
Yeah, I think, you know, none of us want to be further stigmatizing or creating, you know, already internalized stigma to be worsened or deepened. And this is where the sort of like we are, isn't it? I mean, there's fantastic work that happens under that banner of weight management. You know, I really feel for the people that are tasked to deliver on weight management, because they're all health professionals and they all actually wanted to deliver on health. So how do we make every contact how do we start to offer services that are non-weight surveilling? That's part of the solution, I think. And you know, that's a huge barrier. And the data that I've put in the chat throughout today's session is, you know, we are achieving little by focusing on weight. And we've been doing it for 60 years now. So if it was going to work,
it's not working. Yeah, exactly.
Yeah. If it was going to, it would work. And we go, oh, well, we've got the injections. Well, it's really, really important now that we don't take the totalitarian route of saying, you've got to take these jabs. You know, everybody needs to be thinned. You've got to take these jabs. It's really, and that's why it seems sensitive to talk to people about their weight, because it absolutely is. And I think we should be having less weight conversations with people and more health conversations with people. And we've got training for that to increase confidence around destigmatizing every situation. And yeah, we'll keep asking for meetings to talk more about that. You know, so yeah, thanks for running the session, and because I'm always open to hear that the evidence that focusing on weight is more healthy. Always open to hear that, but haven't heard it yet.
Brilliant. Thanks, Helen. Any other thoughts or reflections, Paul?
Yeah, I'm thinking of the bookends of it all, I think. But on the other side of it, it's how does it become an ongoing thing with the health? So obviously they might be put into something or other that then supports them for a certain amount of time, but then it stops, and it's how you create that ongoing support. I remember there was a lady, and this is kind of more in the health again, but there was a lady who was going to the leisure centre that we filmed on a health thing we did a couple of years ago with this project, and she was so positive about going to the leisure centre and the community that had built up. I don't know if it's something to do with like the health community thing that made her keep going, but she was really raving about it. She goes swimming, and because of her swimming, her back's got better, and this has got better, and the other things got better, and her weight had gone down. But I think it was the community bit that kept her going back. I don't know if there's something in that, but that's probably the tricky. I suppose it's even like the jabs. When I've spoke to people who've been on the jabs and things, they come off it. I don't know if this is the case for everyone, but a couple of examples, they've come off it and then said it's been hard because the appetite comes back like 100-fold. And so that's again sort of managing the you do the initial interventions or whatever, but then how do you then
it's only part of it? It's just a small piece.
Just my musings.
Cool. No, thanks, Paul. All good. Craig.
It was just on that point that Paul made there, really, around so within public health messaging, you've got the rainbow like Dahlgren and Whitehead, and it'll reference things around social networks or community and things like that. There's some things obviously people have more control over than others, and like it also, I guess, links in that perception for that person going to that leisure environment. The perception could be this is having an impact. The thing we've got to be careful with, and what it was brought up before about the injections, is that people then may perceive that they're going to be on these injections for a longer period of time and that everything will work out better for them as well. I won't say for this specific population around severe mental illness, they might be impacted more by it. But it's just one of them things that we'll really have to be careful about it, because it's, when we talk about behavior change and that what underpins making every contact count, it's them. Everyone would, or not everyone, the majority of people would really love like a quick fix if it's a case of whatever, for whatever we're going to be talking about. So ultimately, we've got to be really careful about managing those expectations, about making those changes. It's going to take time for those habits to form. And it might be that for the leisure setting, that community impact kept that person going, but the added benefits or bonuses was becoming more physically active, maybe improving mental health and well-being, that social interaction, that community, and getting new friends. It will differ, but yeah, I think there's those really key points are probably looking at the wider impacts of things, but also perception against expectation, because yeah, it's, I mean, like, you can buy injections online from people and stuff like that, and if people do that, then actually is that the quick fix that then has a negative impact on health services, because people are getting things that isn't actually what they think they are. So yeah, just to follow those 2 points up there.
Yeah, really good, Craig. Thank you. Susanna, is there anything you'd like to just finally add before we just do the final couple of Slido questions?
Well, I think it's been a really helpful discussion. So thanks for people's reflections. I suppose just to add from the perspective, we're focused on severe mental illness here, but I think we could equally have chosen people with specific needs in various different aspects of life. I mean, the term vulnerable groups can be pejorative sometimes, but people who are experiencing, we might be thinking about people who are living in food insecurity, or kind of perhaps the maternity stage of life, or different points of the life course. So I think almost everything that we've shared in terms of reflections would be relevant to those more kind of separate nuanced contexts. So I think that's just perhaps helpful to bear in mind for the MEC model as a whole, that perhaps lots of this learning is transferable to those different settings. So thanks for that, everyone. But otherwise, yeah, I think actually let's shift on to the next last little bit before we let people go.
Brilliant. Thanks, Susanna. So you should be able to scan it with your QR code, or you go to this slido.com and you can pop the number in. So we'd like to hear, based on what you've heard today, what have you learned? So you're all typing away. Thank you. There's lots of typing, so there's clearly lots of learning, which is good. People are writing essays. Fab, I'm glad to hear. Yeah, brilliant. Good to hear that, yeah, you enjoy the collaboration and reflections. Brilliant. Fab. Brilliant, folks. Thank you very much. Then we've just got one final question to ask of you. Just going to go to the next one. Hopefully that's changed. And here we would like to hear, what do you think you could do by the next community of practice session around what you've heard? It would just be great to hear something tangible that you think you might be able to take forward by the time we next meet, based on what you've heard. Oh, who's going to get there first? Do it as a race. Brilliant. Revisit MEC site, aware of challenges of vulnerable groups. Brilliant. Oh, Nutria will be roundtabling at BMG conference. Must stay open to hearing the evidence that supports health. Amazing. Oh, advocate weight stigma training from Nutria. Brilliant. Yeah. Fantastic. No, that's amazing. Thank you ever so much, everybody. And then just one final ask from me. In terms of the sessions going forward, it would be really great to hear from you all in terms of what kind of topics you would like to hear more about. So what I've done is on our Padlet that we've got going, I've added an extra tab where you can pop in there any topics or things that you would like to hear about in some of our future sessions. So it'd be really good to get your thoughts on that. So I'm just going to pop the link to the Padlet in the chats. That fortunately, it looks like that's worked well. Happy days. So yeah, so please pop in there what you'd like to hear at future sessions, or if any of you would like to come along and share and promote your work, please get in touch. That would be great. And as I said, I will download these the discussion points from the breakout rooms and also the Slido results as well. So we've got them for next time, because it'd be great to hear how you've got on with these actions at our next community of practice session. So thank you so much, everybody, for coming along. Thank you so much to Susanna for sharing that evidence with us. I think it's really thought-provoking and brought some really good discussions to the session. And yeah, hopefully we'll see you guys all soon. Brilliant. Take care, everybody.
Thanks, Ashley. Thank you.
Thank you. Bye-bye.
Bye.
Thanks. Bye.